get better as you get older. However, inattention persists, more into later on in life. And so attentional problems tend to be more stable during transition to adulthood and predict wider problems. So when I see children with combined type of ADHD or just inattentive subtype, so that is something that gives me a sense of how things are going to be for them into adolescence and adulthood. So when we look at core deficits, we really look at executive functions. Okay, so what are executive functions? Can someone give me an example of executive function? Like what? So planning, problem solving, okay, judgment. So these are all frontal lobe, okay? Frontal lobe functions. What is another disease that affects frontal lobe and problem solving and executive functions other than ADHD? What is another disease that affects, it's not the same mechanism, okay? But it's a problem of executive functions as well. Does anyone know? So Alzheimer's disease is another one of these problems with planning, executive function, memory, okay? So they're on extreme ends of the spectrum. Like, we see ADHD in children, we see Alzheimer's in elderly. You're going to probably take Alzheimer's at some point. So mechanism different, but executive function problem. So it's a wide range of central processes, okay, so that they connect, prioritize, integrate functions. And the main thing that we talk about is really the working memory. So this is the short-term memory that really functions in order for you to learn. So if someone gives you, and how one of the ways we test working memory is to give somebody a set of numbers, a set of numbers, and then you ask them to recall them later on. That's one of the things we do test in terms of ADHD. And you'll find that people with attentional problems have issues with short-term memory. And that's why, the ability to learn can be impaired. So prevalence really varies across studies from 1.9 to 14.4. And again, in some areas, it's under-recognized, it's under-diagnosed. In some areas, it may be over-recognized, over-diagnosed, so you have this wide range in prevalence, but it's mainly a disorder of childhood. And as people get older, like I said, sometimes it could remit. It is more commonly seen in boys, affecting all levels of IQ and socioeconomic status. So nobody's immune from this disease, like disorder, if you will. Regardless of how rich or poor, how smart or not, ADHD can occur. So with regards to the diagnosis, I don't want you guys to memorize the absolute, symptoms. So this is just an overview for now, okay? But it is a persistent pattern of inattention and or hyperactivity, impulsivity, interfering with function or development. So this is really a key factor. Sometimes we see people with symptoms, but they're functioning fine. Okay, they're doing okay at school, grades are high. So do we intervene or not? So we usually don't intervene unless there is a disturbance in function. If this child is not achieving as they should relative to their intelligence, okay, so you'll see things like in the report card, could do better if studies, could do better if pays attention, can be expected to do. So these are kind of very common statements made in report cards of children with ADHD that just kind of point to the fact that, if only this kid would sit, if only this kid would pay attention, they could do much better. And so there we have a problem with function as well as development, because obviously if you're not achieving in your learning, then, developmentally, that's going to be an impairment. So usually you want 6 out of 9 symptoms of inattention. However, this is a change with DSM-5 because in DSM-4, this was not present in this particular sentence where they said that you could have at least 5 symptoms if you're 17 and older. Also for hyperactivity, impulsivity, you need to have 6 out of 9 symptoms. And again, you need only 5 if you're a bit older. And symptoms need to start prior to the age of 12. In the DSM-4, it was the age of 7. Okay, so they've kind of pushed the age range a little bit. Very important is that you need to have symptoms in 2 or more settings. And usually, what are the settings of a child? When they say 2 or more settings, so what are they referring to? Which settings? So class and so school and okay, so school and home. So what happens if you have a child who only has symptoms at home? So at home, they're disruptive, they're impulsive, they're, all over the place, but at school, there are just no complaints. What would you say there? Where's the problem? So maybe it's a family issue, problem in the home. So usually it's a parenting issue. Okay, so the parents are just not able to set rules, discipline. Maybe there is a lot of discord, conflict. Maybe there's abuse. Maybe there's so many things at home. Okay. And if it's the other way around, that this child is, everything is, perfect at home and there's just problems at school. If the school is just constantly complaining, okay, so they could be not interested. Maybe it's not the correct setting. I've seen gifted children, okay, so where the IQ is over 120. So these are like, it's a genius child who is presenting with ADHD symptoms. And when we actually tested this child, it's not that they have ADHD, but the environment was not stimulating enough, okay? Too much students in the class, agreed, because, if you have a child in a class of 40, and this child maybe needs some direction, so they could look like they have ADHD, okay? And like I said, functional impairment is essential. Okay, so I love using cartoons to kind of compare. So Tigger is a perfect descriptor for a hyperactive, impulsive child, because again, Tigger is a lovely person, lovely character, a tiger. So if you know Winnie the Pooh, so Tigger is from Winnie the Pooh. And then Dory is the inattentive, memory impaired fish. Obviously, she has a short-term memory problem, but I mean, kids can relate to cartoons. So if you kind of talk about Dory, then, children with inattention can kind of relate to how that is. And again, Dory is loved and is pleasant and is funny. Okay, so what does ADHD look like in the preschool child? So there's a lot of motor restlessness. They're kind of spilling. They're curious, so therefore fearless, not very compliant. They could be a bit aggressive, demanding, noisy, interrupting others. So this is like somebody who's in KG. This is what it looks like. School-aged kids, again, grades 1 to 6 or 1 to 9. A lot of incomplete work. They blurt out answers. They can't really wait their turn. They're very distracted. They're usually interruptive, aggressive, can't follow rules. And again, at home, maybe have difficulty with doing chores or, kind of responding to parents. The adolescence, again, it's kind of a difficult time. Remember when we talked about adolescence in general? So it's a time for when kids want to be autonomous and individual and all of that. And if you have ADHD on top of that, so they have a sense of inner restlessness, very disorganized, very dependent in work. They could also engage in risky behavior. So what is risky behavior in adolescence? What does that mean? When we say risky behavior and if we're worried about risky behavior. So drugs, yeah, what else? Crime, okay, crime. So reckless driving, okay, is another risky behavior. Being promiscuous, again, like not being careful in relationships. So why risky behavior? So these children or teenagers are full of energy, okay? Very impulsive. And so when you're impulsive and you're a teenager, so again, your interests where you could be impulsive are not like when you're, in school, like if you're a child. Again, adolescents, they've already reached puberty, so there are a lot of hormones. So risky behavior could be sexual, could be substance, driving, crime. So these are things that are interesting. Like I said, remember when we talked about the PlayStation and the game? So they engage, they're more enticed by things that are like more dangerous. So the adolescent with ADHD who's really impulsive is usually the one in the crowd where the friends set them up to be the one to kind of do the thing. So go ahead, you do it. So they're usually impulsive. So they'll be the one to hit first or, do whatever they're not, because they're not really thinking through. All right. So their friends will push them because they're the ones that are all hyped up. And then suddenly they find that they're alone because everybody else ran. And so they're the ones that are in the scene of whatever. And so that's why they get into trouble. Because again, they don't process. They know it's wrong, but they're impulsive. They get hyped up in the moment. So they end up in trouble a lot of times. Poor self-esteem comes from poor achievement over life. Poor peer relationships, it's difficulty maintaining relationships because of impulsivity, so they lose friends along the way. And again, clashing with authority because they're argumentative, they're belligerent, and also feel very entitled because they're kind of impulsive and macho. And so run into problems with authority. Usually at school, it's with principals, teachers, and so detention, stuff like that. The adult, okay, again, continued story, distractible, restless, problems with planning and organization. And so why would that be a problem if you're an adult? If you're having issues with organization and planning? Why would that be a problem? Okay. Okay, so how can the family deal with, we'll talk about management in a bit, but why is it a problem if you're an adult with poor planning and organization? So I have the mother of a child I used to see who has ADHD. And so this mother has had issues with employment because she's not able to maintain a job because she has very poor organizational and planning skills. Okay, so she can't plan meetings, she forgets agendas. Okay, so she's not been able to hold a job because of this. And so she contacted me a few weeks ago and she said, like, I think I need to be screened for ADHD because I think I may have ADHD. So poor memory, emotional distress, frustration, low occupational achievement, difficulty finishing daily jobs, family problems. This mother of a child with ADHD whose husband, so the dad has ADHD. So one of the problems was he'd always forget his keys. He'd forget where he parks his car, sometimes forgets to pick up the kids. Okay. So you can imagine how these things can really spill into the marriage where, there's always arguments about how he's always forgetful and whatnot. Multiple marriages, getting bored. So again, we see that sometimes adults with ADHD, it's from one marriage to another. Comorbidities, again, is the rule, motor vehicle accidents, and then rule breaking behavior. So getting into the justice system. So again, very diverse, complex presentations, very important, again, to remember the idea or the concept of comorbidities, as well as a delay in diagnosis and adequate intervention. So that will spill over into getting sort of treatment delay. So this is just a kind of a figure of hyperactivity, impulsivity, and then that these kind of get better with time, inattention persists. So what about etiology? So why does it happen? So usually when there's so many, like when it's multi multifactorial. Okay, so that means that there's just not one cause, but there is a very high family and genetic background to it. So it's important when we take a history to ask about other family members with ADHD. Sometimes prenatal or perinatal factors, so in utero infections, perinatally, asphyxia during birth, so like low oxygen affecting the brain, toxins, whether, again, being exposed to toxins while a mom is pregnant, acquired and traumatic. So we've seen also that sometimes post-head injury, children develop, as well as adults, develop ADHD symptoms, and acquired infections, like I said, seizures. So seizures are a common reason for why kids could then become inattentive, because they have uncontrolled seizures. And then psychosocial stressors. Sometimes, and again, we also notice that if you're extremely stressed with so much going on in your life, you're like your memory starts to kind of fail you, not because you have a memory problem, but because your system is really overloaded. Okay, so there's no test that can make a diagnosis. Okay, so parents come in, they're like, can we do a blood test for ADHD? No, we cannot. Can we do any imaging? No, we cannot. So it is a sort of a collective set of symptoms with a kind of cutoff. If you meet that, then you qualify. Plus, again, in more than one setting, as well as functional or developmental impairment. So we generally have to consider many things. You have to take history from related to home, school. We have to consider differential diagnosis, organic disorders like thyroid abnormalities, because people who are hypothyroid could have attentional problems. People who are hyperthyroid could be really like restless and fidgety. Functional disorders. So people with hearing impairment, I remember like one of my first assessments during my residency, where we went out to a school to assess this child, a 4-year-old in preschool, who was presenting with attentional issues. And then, after the assessment, it turns out that he has nerve conduction hearing problems. So it's not that he's inattentive, he's poor guy's deaf. All right, so that could look like they have ADHD. And then developmental disorders, kids with global developmental delay as part of a syndrome are also going to have attentional problems. So the main problem is not ADHD, it is the developmental problem. And again, you need to consider comorbidities. They are the rule. 50% of people with ADHD have oppositional defiant disorder and conduct disorder. Again, you're not required at your level to know what these are, but if you're interested, you could always look it up. But these are pretty serious behavioral issues that co-occur with ADHD. 25% have a learning disability, so they could be dyslexic, which is a reading problem. They could have a mathematics disorder, a spelling disorder, so a learning disability. A third to 2/3 have a mood disorder. A large percentage have an anxiety disorder. So this is one of the most common as well, comorbid issues. So when we screen, we have to screen for this as well, because sometimes the treatments that you give for ADHD, which is, stimulants, they can make anxiety worse. Okay, so what are the sort of practice parameters for assessment? So you have to do a good history. You need to get collateral information. So collateral information is not only information from the parents, but also from the school, because you want to see how this kid is doing, everywhere. You need to make sure that you've done a good medical evaluation to rule out any sort of medical conditions that could look like ADHD. We use structured interviews, so checklists, and we do psychometric testing, which is we're going to take in another lecture. How do you do it? What is it exactly? So again, we're going to kind of skip this. So when you present with impulsivity and inattention, you have a wide range of dysfunctions. So you have functional impairment in terms of repeating a grade. Like I said, teen pregnancy, because they're, engage in risky behavior in adolescence, sexually transmitted diseases, substance abuse, injuries, being incarcerated, fired, and attempted suicide. Again, many areas of dysfunction. So obviously the quality of life is going to be impaired or affected. There's increased cost to society, and obviously loss of revenue to the society because, you know, if you're not working, if you're unemployed, then, you know, you're not giving back. So symptoms, again, in any domain, all right? If you're hyperactive, impulsive, or inattentive, it kind of spills over into your entire, like many domains of your life. And therefore, it is really a significant public health concern, okay? The impact on managed care. So managed care is, so if somebody has a disorder, how does that play out in terms of, just a second. Okay, so managed care in terms of the cost to society. So it affects almost 8 million adults. Again, this is a US percentage. So there's direct cost to the disorder and there is indirect cost. So treating it and its comorbidities, and the indirect cost would be reduced productivity or lost earning potential. Okay. The direct cost of treatment, we're talking about billions of dollars, whether it's related to the disorder itself or its comorbidities. So smoking is a problem with ADHD, okay? And again, with smoking, you have smoking-related public health problems, okay? Children with ADHD are more likely to smoke, more likely to start smoking at a younger age than those without ADHD. Sexually reproductive risks. So again, they can begin sexual activity earlier, more sexual partners, less likely to use contraception, again, because they're very impulsive, higher risk for STDs. Now, when I was doing my residency and we came across an adolescent with ADHD, we had to educate them on, you know, sexually reproductive. Can it be because smoking helps them concentrate or relax? So it doesn't really help them concentrate, but it could kind of help them relax. And that's why, you know, when you assess somebody with ADHD, there comes the option of to treat or not to treat. And usually if you don't treat, kids will find their own ways of kind of calming themselves down. And unfortunately, it's going to be, you know, with substance, so marijuana, alcohol, are things that help people kind of chill. They're less restless. Smoking as well. So that's why not treating ADHD puts people at higher risk. So like I was saying, so if you're treating an adolescent, you know, you're obliged to educate them about, you know, sexual issues because you have to make sure that they understand protection, okay? For adults, as well as teens, you know, a lot of problems with motor vehicle driving. Either they're driving without a license or it's revoked, or they have accidents. And again, if they have comorbidity, it increases the risk. So substance use, alcohol, marijuana is going to increase the risk. So the indirect costs are things related to, you can have two people who have the same educational level and IQ, but if they have untreated ADHD, they're less likely to achieve in their life, academically as well as occupationally. Again, so we share some of these statistics with parents because we want to make sure that we're, you know, you give them information so that they can make an informed decision. This is really important in any area of medicine. So informed decision, you give them information, they make the decision based on what they know. Obviously, there's going to be some situations where you as the expert, you know, have to kind of like jump in and make the decision at times when there is a risk. Okay, so if you have a suicidal teenager, obviously, you know, there's no room for asking them what they want to do. Obviously, you're going to have to, you know, take charge and manage the situation. Okay, again, the same area of like problems with income, quality of life, and problems with behavioral dysfunction if untreated. So reduced functioning and results in low self-image, marital problems, and increase in criminal behavior. So ADHD in the justice system. So if you follow children to young adulthood, these are more than likely twice than others to be arrested. okay? 25% of inmates are going to have ADHD, okay? So that's really a high percentage. So a quarter of people in jail, if they were screened, they will be found to have ADHD. Now, had these people been, managed earlier in life, maybe they would not have ended up in jail. Okay, so that's why it's really important to prevention. So early detection, early diagnosis, and early intervention. Burden on families, I can't explain this or can't stress this enough. We see parents and partners of people with ADHD, so a lot of stress, employment disruption, a lot of marital discord, substance use disorders. This is kind of what a caregiver of an ADHD child could look like. I've seen moms where they don't know what it's like anymore to socialize because of how difficult it is and the struggles that they have with their kids. So do we treat or do we not treat? What do you guys think? Treat or not treat? Yes, treat. So depends on degree, okay? What does that mean? What does it mean to depends on degree? Okay, so severity. So severity is, it's kind of very subjective, okay? So a teenager who's failing doesn't really think they have a problem, they're just hanging out with their friends and they're chilling and hey, what's wrong with skipping class and what? So a teenager is never going to think that they have a problem and they're not going to see the impairment, okay? So it's a difficult age to deal with because their insight is kind of really they're just looking below their feet. There's no foresight, okay? Can you treat an adult with ADHD if they don't see that they have a problem? Let's say wife brings in husband and he's all over the place. And if he has no insight, so can you treat somebody who doesn't want to be treated? No. What about a teenager who has no insight? Can you treat a teenager who has no insight if they don't want to be treated? Yes, with a question mark, yes. So how can you treat an adolescent if they don't want to be treated, but then you can't treat an adult if they don't want to be treated? So what's the difference? So because they are not adults yet, okay, so as kind of not nice in terms of how it sounds, but they are not their own guardian, okay? The parent, thank you, the parent or the guardian makes the decision, okay? So this teenager, unfortunately, is going to have to, play along. But what's really important is that you are able to develop a therapeutic relationship with the teenager so that they believe, because in fact you are on their side, okay? And you're working with them to kind of reach a goal that they want, okay? It's not about what the parents want, but it's about, so we always try to find a way in. So when the parents tell me how do I bring my teenager in who's got ADHD, who doesn't think they have a problem? So what would you tell the parent? The teenager does not believe they have a problem, but obviously parents need to bring them in. They cannot drag a 15-year-old into a clinic. So what could they tell them in order to kind of convince them to come in? What do you guys think? Show them that they have a problem. First thing the teen is going to say, I'm not the problem, you're the problem. Okay. Video of their actions. They're going to say, are you spying on me? Where is my privacy? Okay. So maybe, okay. So one of the things is, again, they don't have the insight. So one of the, usually teenagers have issues in terms of, relationship with their parents. They usually have problems getting along. And the reason they're not getting along is because this kid has ADHD, but we're not going to say that. So, parents can say, listen, we've been struggling lately, all of us, in terms of how to get along. And I think maybe it'd be helpful to go to someone who can help us figure out why we can't get along. Okay. So that really removes the blame. You're not pointing the finger at this teenager, because the minute you start to point a finger, they're not going to go with you anywhere. But when you start to remove blame and you kind of, let's say it's diversified and it's diluted, they'll be coming in to complain to you about how nasty their parents are, which is great. That means they're in on it. And okay, so you try to kind of find an external, or if they're having problems with friendships, that's usually another common way to come in. Let's try to figure out, what's the problem? Why is it that your friends are not being nice to you? When it's actually that this kid is super hyperactive and super impulsive, and that's why they don't have friends. But again, we're trying to remove blame. So we definitely treat when they're younger and they are not their own guardian. But if it's an adult, okay, then you cannot treat if they're not on board. Sometimes they are referred to you for compulsory treatment because they're going to get suspended from their work. Okay. So like I said, this mom, part of it, she was going to lose her job, her current job, if she didn't figure out what was her problem. So sometimes they're forced to come and find treatment, or else they're going to lose a job, or like wife says, listen, you better figure it out, or this marriage is over. So there's usually an ultimatum. But I'll never forget this. When I was in private practice, this dad brings in a 12-month-old. Okay, so they call up the clinic. They're like, they want to come in and see a child psychiatry, and the child is 12 months old. And I was on the phone. I'm like, are you sure you want to see psychiatry? Maybe you want to see pediatrics? They're like, no, we want to see psychiatry. So dad comes in and mom. And so this dad is like, and this was in Jeddah. And if any of you know Jeddah, so there's Medina Road, all right? And then there's a lot of these billboards. And now in Malik Road with that, that building with the screen. So it was back in the time where it was just Medina Road. And so this dad's like, I have had so many accidents in my life just because I get distracted on the road. And I don't want my child to be the same. So I want to make sure that they don't have a problem. Okay. So this was a very insightful dad. And he was directed to adult psychiatry and was assessed for ADHD. What if the family of the child does not want them to be treated because of concerns about the use of medications? Okay. That's a really good question. We'll talk about that. We have 10 minutes. Now, in terms of the treatment, I don't want to go over the details. You have this presentation, keep it. It'll come in handy later on when you're in pediatrics and you want to kind of go over it. But I'm not going to go over the specifics of treatment. Okay. I'm just going to give you some names. But specifically, I will focus on Ritalin or stimulants because they're the most common, okay? You need to make an accurate diagnosis, make sure that you don't have comorbidities, okay? So this is a treatment study, okay? I'm just going to give you a brief on it. It's a multimodal, multi-site treatment. So they looked at 579 children over 14 months in 6 sites. This is kind of the biggest comparative study for ADHD. And they're looking at treatment arms, okay? So they compared combined treatment, which is medical management, okay? They kind of divided it into 4 arms. So either you get medications, or you get behavioral therapy, or you get both, okay? Or you get only behavioral therapy, okay? So medication management, behavioral management combined, or you get medication management from your GP. So medication management by psychiatrist or by your GP, okay? So they found that combined treatment was the best, okay? And that if you gave medical management alone, even if it's by a general practitioner, it was better than just behavioral management, okay? So someone who said, what if parents don't want to give medications? So you have psychosocial treatments, but I always say, and I always compare ADHD to diabetes, okay? So ADHD is a problem of dopamine. There's not enough dopamine in the brain, and therefore circuits are kind of short-wired, and that's why these kids are inattentive and hyperactive. The same way that, insulin-dependent diabetics need insulin, because no matter what you do in terms of cutting down on their diet or managing their diet, they're still going to have problems with blood sugar. And so that's why they need to be on a replacement for whatever it is that their body is missing. So pharmacotherapy, actually medication therapy, is the, let's say, the core of the treatment. But obviously we have parents who come in who don't want that. And so what we do is we offer psychosocial treatment. We offer behavioral modification, parenting, the whole 9 yards, knowing that it's not going to work. Okay. It's not going to manage their inattention, impulsivity, or hyperactivity. However, after parents have tried this for around 3 months, they come back and then they're like, okay, now we're ready to start treatment. Okay. We never force it. We never say, well, you know, it's the pill or in my way or the highway, because they're never going to come back. And that's not the objective. The objective is you want them to come back because you want to make sure that this kid is fine. This teenager is fine. So you need to give them options. That's why I'm saying it's really all about informing the parents of options that they have for treatment. And so therefore, they can make an informed decision. So we're just going to go over 2 minutes with pharmacotherapy. Okay. So psychostimulants are the mainstay of treatment, but then there's other types. Okay. So there's not only stimulants, but there's other medications as well. But stimulants, again, are effective in 99.9% of people. And the side effects, again, they decrease with time. Response rate is really very high, okay? So what do? They improve cognition, they improve vigilance, they improve reaction time, improve short-term memory, as well as their ability to learn. They reduce impulsivity. Children are less noisy, and the mother-child interactions are much better. So it's like a switch on, switch off. Okay, so I had this mom who, once she started the medication, she sent me an emoji with tears. Like, you know, she's like, this is like night and day. She could not believe how her child has transformed. And again, these, important for you guys to know, this is not an indefinite treatment. Okay, very much like, you know, if people are diabetic on insulin, if they don't take insulin for life, they are going to continue having problems with their blood sugar. I mean, fortunately enough, with ADHD, we know that there is about 30% of people who then will not continue to have symptoms into adulthood. You know, maybe 60% will persist, but around 30% will not. Okay. And so they are not going to be on medications indefinitely, again, depending on impairment and function. So how do stimulants work? It's all about reuptake of dopamine. So this is the synapse, okay? And so what stimulants do is they make dopamine more available in the synapse. So reduce its breakdown, reduce its reuptake, so it's more available in the synapse. And so therefore function improves. So again, this presence in the synapse is temporary. So the duration of action of these stimulants varies. I mean, in the United States, probably there's like, I don't know, 10 stimulants of different kinds, whereas here in Saudi, we just have 2. We have Ritalin and we have Concerta. These are the only stimulants. Ritalin is short acting, so it lasts for about 4 hours. So kids need to take about 2 to 3 doses a day. Concerta is a 10-hour pill, so they can just take 1 pill a day. The difference, again, Concerta, you can't break it, you have to swallow it. So if you have a 5 or 6-year-old with ADHD, they're not able to swallow. Obviously, the drug industry has modified stimulants. So now you have patches, you have liquid, you have like a spancel, so you can just kind of sprinkle it on food. That's available in other parts of the world. Some of the common side effects is loss of appetite, insomnia. So they're the 2 most common side effects. Or this zombie-like state. So some parents are like, I don't want my child to be a zombie, because if you give stimulants and the dose is a little bit on the high side, they will look like they are a zombie. Okay, so basically, when you treat ADHD, you reduce the risk of substance use disorders. You improve in so many domains, self-esteem, as well as achievement and relationships. So like I said, Ritalin and Concerta are the available ones in our market, but these are like the ones that are available elsewhere. Okay. non-stimulants that are used, and then, the more newer medication being Strattera. I don't know if you guys are going to take any of this in pharmacology, if you're actually taking it right now. I'm not sure. You may come across it. I just want you to know the name for Strattera, the atomoxetine, but I do want you to know a little bit about Ritalin. So the slides that we've covered on Ritalin or stimulants, please make sure you know those. All right. Basically, we're talking about comorbidities. And so we've already said that they could have depression, they could have anxiety. Again, I'm not going to go over tic disorders, but that is another comorbid problem, that sometimes kids with ADHD have tics. And there was a concern that maybe if they're on stimulants, their tics get worse. So it could happen, but the stimulants are not the cause of their tics. Then one area that is a concern for a lot of parents is, this is a controlled medication. Am I giving my child drugs? Okay. So, and another question that people ask, and that is, can I just take Ritalin just before my exam? So I've had students ask me that who do not have ADHD, can I take stimulants? Maybe it's going to help my performance. So the answer is definitely no, because ADHD is a dopamine deficiency problem. So that's why when you give stimulants, you are kind of replenishing or restoring dopamine stores. Okay. If you do not have ADHD, you're going to overload your system with dopamine, and therefore you're going to push your brain to psychosis. And that's what happens when people use stimulants when they don't have a disorder. They're at higher risk for psychotic disorders. Okay. So definitely not something that anyone would want to try. And the reason we say that these are not substances of abuse is that they don't cause the same psychological addiction that substances of abuse do cause. And because the washout for stimulants is really quick, they're not in the system the next day. Okay, so they're very safe. Okay, so the psychosocial, this is going to be our last slide. The psychosocial treatments, it's a lot. So there's obviously a lot of psychoeducation. We do that anyways, whether we're going to give medication or not. We have to educate parents. And usually the first time I sit with parents, we make the diagnosis over a few sessions, because although I can see that the kid, making cartwheels coming into my clinic, and they're like all over the place. So I know this is ADHD. Parents know that this is ADHD, but trust you me, if you continue to be very organized in the way that you take a history and you do an assessment, you will never go wrong. The minute you start to, make a diagnosis without going through the process, that's when mistakes are going to happen. So again, 20 years into my career, I'm still going to spend an hour doing an assessment regardless. The diagnosis is obvious the minute they walk in, but I'm still going to do the process. So I'm going to make sure that these kids are medically fine. I'm going to make sure that I've gotten my history. I have, all the information that I need. I'm going to make sure that, they're seen by a psychologist to do an assessment to make sure that they don't have a learning disability. So I'm going to make sure that it's as comprehensive as can be. And then we sit and do like the session to discuss the diagnosis and the treatment options. Okay, so it's very organized. It's very, and that makes it better for parents in terms of accepting a diagnosis. Because if you see a patient and you say, like, after 5 minutes, your child has ADHD, here's the prescription, see you whenever, do you think this parent is even going to trust your assessment or diagnosis? Of course they won't. You spent 5 minutes, versus if you're very thorough and you spend time, okay, and then you give them a diagnosis based on your assessment, it makes sense. And so they're going to be compliant. So things like parent training, classroom interventions, all sorts of social skills training, as well as individual therapy of the child or adolescent, depending on if they have also anxiety problems, self-esteem, social skills, depression, So it's kind of a garden variety of things that we can do in terms of the psychosocial. So I hope that answered the question for the person who's saying, what about parents who don't want to give medications to their kids? And that will be our last slide. Thank you so much for being attentive. I'm going to send this lecture so that it gets uploaded and you guys have it. What is a somatic growth growth in somatic side? So sometimes kids, because of very poor appetite, so they're not eating, okay? So there was like another myth that stimulants cause growth retardation. You know, kids don't grow tall. And so this is a myth because you're never, as a physician, going to let a child stay on a medication and they're not eating just because, you know, you want to improve their attention. The minute it starts to compromise their health, obviously we're going to stop it. But I always tell parents, you know, if the child is, if the parents are short, if the family is short, constitutionally, this child is not going to be a very tall one. Okay, so the constitution depends also on the familial part. Also, we always measure height in our clinic to make sure that these children are growing well. They're like on the growth curve. We give them breaks from the treatment during holidays. So they have drug holidays as well to compensate if they're not eating as well. So it's pretty comprehensive. All right, so there's more questions. I think we have to end. So you guys can email me, okay? Please email me because we have to end and I have to run because I have a clinic. It was a pleasure talking to you guys. I'll see you tomorrow in BHS.
Thank you, doctor.
Thanks.